Welcome to the Jena Club of Cardiac Surgery Enthusiasts.
We are a group of young cardiac enthusiasts exploring the world of heart surgery from every angle.
From the lecture hall to the simulation lab
to the doctor's office, where we dive deep into patients' care.
We're here to share the realities, challenges and thrills of cardiac surgery.
We will talk about groundbreaking research and innovation in cardiac medicine. And yes, sometimes we will bring you the lighter side of surgery too.
Get ready for stories, insights and interviews from the heart of the city of science, Jena, Germany.
We are cardiac surgery enthusiasts and this is our podcast. Enjoy the episode. Welcome to today's episode. For decades, she has challenged conventional norms in coronary surgery, championing the use of arterial grafts for their durability and long-term benefits. Her voice has been both scientific and surgical, clear, consistent, and ahead of its time. Based in Calgary, Alberta, she has served as a cardiac surgeon at Living Cardiovascular Institute and the University of Calgary. She has combined clinical excellence with a passion for teaching and research. Today, we are joined by Professor Teresa Kieser. Professor Kieser, it's a pleasure for us to have you on our podcast.
No, thank you for that very elogious introduction. Timur and Angelique and everybody listening, I'm an ordinary everyday heart surgeon. I just do a lot of arteries, okay? That's what I would describe myself as.
Before we start with our conversation, I would like to introduce to our audience, because it's her first time in our podcast, as I said, Angelique.
Well, thank you, Timo, very much for that kind introduction. As you already said, my name is Angelique. I'm a medical student at the University of Jena, and I will start my residency in cardiac surgery next year. So I am really looking forward to that, just as much as I'm looking forward to today's talk. So, dear Professor Kieser, thank you very much again for participating in this video podcast. And in order to dive into the main discussion today, I would like to take a moment to reflect on your extraordinary career. To my knowledge, you graduated from the University of Ottawa in 1976, but I like to go back even a bit further, and I would like to ask you, what inspired you to become a doctor at first? Was it like a childhood dream, or maybe more a matter of fortunate circumstances at the time?
Well, I wanted to be a ballerina.
Oh, for real?
Intense training. Yes, that was my career since age 3. And I wanted to dance. I danced for 10 years. I went to national ballet schools, summer schools. I auditioned and everything, and I didn't have the right external rotation of my hips. But I even got at age 16, I was an associate with the British Association of Teachers of Dancing, BATD, in ballet, tap, and stage. And I couldn't think of anything else but dance. And it was not going to happen. Betty Oliphant, the head of the National Ballet School, said, she's very talented, but she would only get as far as the core with her external hip rotation. And she's very intelligent. She should use her brain. And I thought, nuts to that. Anyway, so my mother kept saying to me, Teresa, why not? Have you thought of medicine? Because I had two brothers and sisters in music and one in science. And so I said, no. And then one day I can remember it as if it happened yesterday. I was 17 and it was May 18th. I remember the day. And I was just waking up, and you know how the sun comes up and suddenly it just hits you as it rises and it just hits you in the face. And I suddenly thought, why not? Why not medicine? So from that point on, I switched from 5 languages or 4 languages and 1 math to 5 sciences from grade 12, grade 13. And I ended up with the same mark, 87% at the end of grade 13. So I thought, okay, let's go for medicine. So that's how the doctor thing started. And I've never looked back.
We will talk at next about your choice for cardiac surgery, but now I'm curious about, don't you think that dancing ballet it improved your dexterity or your coordination, that sense of rhythmics?
I think, you know what it did improve? It improved my back. It improved my neck. It improved my
important.
body. I've never had problems with back, with anything in it, because you position yourself so that you're standing with your foot extended. If you're having to look down at the mammary, you do ballet moves to keep your body right. So yes, it did help. It also helps when you're giving talks on a stage. I don't mind being on a stage. I love it. It's my dance for days. My daughter takes dance too.
That's actually really interesting to hear. As far as I know,
question,
after
Timur.
your... Excuse me?
Good question, Timur.
Yeah. After your graduation, as far as I know, you served in the military and you completed a cardiology training under the mentorship of the famous Mr. Gerald M. Fitzgibbon, who is famous for the coronary graft patency classification, of course. And as far as I know, you wanted to go into general surgery at that time. What actually inspired you to pursue a career in cardiac surgery? And when did you make that decision? Because we are always told to make this decision as early as possible, when possible already in medical school, so we can get involved into clinical activities as soon as possible. So when did you decide and why?
I've always felt like I was a puppet on a string, doing what the good Lord has told me to do, because my parents couldn't afford 4 children in university for more than 4 years, and medical school was longer. I did get in after 2 years, so it was still 6 years. And so I thought, I know, I'll join the military. They funded you, not the first year, because they want to make sure you're going to pass. So they funded you for 3 of your 4 years medical school. But then you had to give back 3 years in service to the military. And between one and two, or 2 and 3, 3 and 4, and at the end of 4, you had to serve in the military in your summer holidays and work at a military base. And it was basically looking after gentlemen who were a rather large BMI, with sore backs and sore toes, and who were trying to get out of their requisite annual mile and a half run. And I thought to myself, there is no flipping way I could possibly do this for 3 years. There's no way. So I tried to buy my way out. I went to see our career manager. For me, I was in Toronto at the time. We called him the career mangler, fondly. And he said, I said, to buy my way out, I just, whatever it costs, it's fine. He goes, oh no, my dear, we need doctors like you. I'm sorry, no way. But listen, I have a cardiologist in Ottawa at the National Defence Medical Center. Would you like to go and visit him and see if you would work with him? You would be in a hospital. I want to be in a hospital. I want to keep training. I didn't want to stop my training, And so I said, okay. So they flew me up there, and I met Fitzgibbon in the cafeteria one day, and he looked at me, and I said, now, Dr. Fitzgibbon, I want to be a surgeon, and I will do. Well, first he told me, he says, I don't take you for just 1 year. It takes me 1 year to train you. You need to work for me for 2 years. I said, okay, but would you please then, if I do 2 years for you, give me a 3rd year of surgery, which would count as a general surgery towards, because in those days we had to do general surgery and then cardiac surgery. So he said, all right. But he says, the last young woman who said something like that to me quit after 3 months. And I said, Dr. Fitzgibbon, I will not quit. So I went through and did the 2 years for him. And then when I went to actually sat down with him at the end of my 2 years, he said, well, I don't think you really are surgical. I think you'd be better off in cardiology or internal medicine. And I just pounded on my desk and I said, Dr. Fitzgibbon, you promised me you would give me this. I have worked for you day and night. I worked 8 to 10, 12 hours a day for that man. I said, if I had gone to the oral town, how would I have time to work for you? When I'm in Rome, I do as the Romans do. How can you possibly say that? And he just smiled and he laughed back. He said, this is a butterfly of different colors. Okay, I'll give you the share of surgery. So I was thrilled because I got a training out of the 3 years, and I went to mostly National Defense Medical Center, but there was a possibility to do 3 months with Wilbur J. Keown, who was the most influential cardiac surgeon in Canada at the time. And I started that rotation, still wanted to be a general surgeon. And after the 3 months, suddenly I just thought, my God, I'd be an idiot. I know the nurses in the ICU loved me in the cardiac ICU because I could treat atrial fibrillation and heart failure and emergently open a chest. And I thought, this is what I must do. I must do cardiac. Well, who knew? And when I was talking with Dr. Keown about it one day, and he said, Kid, he used to call me Kid. He said, Kid, one day you will step out of your training and open a unit like I did.
Mm.
Which is
And you did. But
I felt like really I was on a puppet on a string. How could I say no to the military? How could I say no to Dr. Fitzgibbon? How could I say no to a 3rd year of surgery? How could I say no to Keown?
Yeah.
It was all planned out for me. So I am here by the grace of God. Thank you.
That's really nice said. Thank you very much for those insights. But as you already said, the ICU nurses really liked you because you were able to treat heart failure, atrial fibrillation, and so on. So what's your opinion on cardiology training for cardiac surgeons? Do you think it is necessary or at least really helpful to become a cardiac surgeon to work in cardiology first?
I absolutely, definitely agree with that. It is, it has given me such an in. I mean, the cardiologists, they loved me. They send me patients. As my husband said, who's got a wonderful sense of humor and a great wit, he said, well, you're bilingual. You speak cardiology and you speak cardiac surgery. And my best friends have been actually cardiac surgeons internationally, but cardiologists, I just love them, and we get along so well. So you can see their point of view. You see so much that what they do for you because they've dealt with some of the problems that we've left them with. We don't follow our patients for 30 years. They do. They know what arterial grafting does. So it's just if you can possibly swing it, 3 months or whatever, it would really be an eye opener for you. And you might get to learn I learned how to do heart catheterizations through brachial artery cut down.
Mm-hmm.
I did the Swan-Ganz catheters through venous cut down. That's what we used to do in those days. I remember Fitzgibbon, he showed, it was like the original show, see one, do one, teach one. One day he said, we're going to put some Swan-Ganz catheters in. So he did one, he did the cut down, and he says, okay, now you do the next one. He left. This was like in the military. There was one time I was in the one of the 3 months. The surgeon the night before said, well, I was general surgeon. He says, we're going to do a radical neck tomorrow. You're going to do it. And I had this is my first year of residency. So I studied like for 5 hours the night before, the whole anatomy of everything at the radical neck. And I did. I mean, this is like throwing you in, head first. But it was great training.
I'm really
I don't think you should do
curious.
that now, though. Sorry, go ahead.
I'm really curious about that technical pathway. You described that you already had some surgical experience, but how did you start, for example, first venous vein harvesting, chest opening? What was your pathway? Because nobody starts directly with bento procedure, for example.
No, I think I started harvesting saphenous vein, but I remember with Willie Keown, he was just really... He just threw you in. And there was one day I was operating, I was assisting, and I had my junior assistant. And I think this is when I was later on in cardiac surgery residency. She was on the leg doing the vein, and I hadn't opened a chest by myself yet. And so Dr. Keown said, sure, go ahead, open the chest. I'll be out here. You call me when you're ready. And I remember Virginia Goodis was at the leg, and she goes, oh, I can't help you. If you get in trouble, I can't help you. I'll be fine. Don't worry. Open the chest. So I think it's a way that in those days, they tested you to see if you had any verve. If you had the guts, you had the balls to do this. But and then I progressed. With Willie Keown, he couldn't stand to watch somebody struggle. He could not stand to train a new person. So either let you do it all by yourself, or he had the the chief from the previous year, who was now a fellow, would assist you. So I learned mostly from Alan Menkes, who was a cardiac surgeon who was chief in Manitoba, Winnipeg for many, many years. So, it's so funny because I remember one day I'd read that you could use the Foley catheter for retrograde coronary sinus venous, retrograde cardioplegia.
Yes.
I said, Alan, this sounds really good. We should do this. He wouldn't let me. He wouldn't let me. He said, you don't have the right. I said, it's a Foley catheter. How bad can it be? And I knew then I was an early adopter, I just wanted to try stuff. But
Yeah.
you got to be safe. So Alan kept me safe at that nascent stage.
That's actually really, really interesting, because I've seen that you received your board certification quite early in your career, and you were very fast. So you were talking about the feeling of just being thrown in. So, but I often have the feeling or experience that that is not the case today anymore. So what do you think? How did residency and training programs actually change over the years since you started your career? Because I feel like the way of residency and training today, at least it is in Europe or Germany, is a very long and demanding one.
Yes, it is. It is very, no, you're right. It is hard, but I think nowadays, I think it depends on the program you go to. I think you've got to really research your program well and just find out from the other residents when do you start to cut. I worked in a program in Calgary that was it's outstanding for training the kids. I call them kids now too. The residents start very young. In fact, when I started teaching, I remember I was teaching a resident how to harvest the internal thoracic artery with a harmonic scalpel. And one of our assistants, who was another surgeon but retired from his active practice, he was taking the vein, and he said, I had to dump 1,000 miles of vein before I could take a mammary. And I said, Kishan, that's the problem. That's the problem with today. My mother used to say, you start the way you mean to continue. I am starting my residence on harmonic scalpel harvest of the IMA. And I devised a teaching program for it. I've written on it. You can see it's published, of how to train a resident. And when you start, you continue the way you may when you start. And it's so true. So now I have residents who are staff who are using the harmonic scalpel. And they aren't scared to try something new. It's the time to try something new is when you're training, because you've got a staff right behind you going, oh, that wasn't so good. You have to fix that branch is bleeding, and this is what I think is, so check your training program out. Just make sure you're going to, and go and see before you start, go and just interview and just get a feel. It's a two-way street learning, okay? You're learning about them and they're learning about you. So if you can get an eye, you can arm yourself with as much information as possible before. Talk to the nurses. Nurses will tell you everything, okay? Be friends with the nurses. I mean, I love my nurses. They're so wonderful. I can remember days where, actually, Willie Keon taught me this. He would, when we're operating, and the nurse would hand him a thing. It'd be the wrong instrument. So he'd just pick at things a little bit and go, okay, now this. Like, he would never say that's the wrong instrument. He was just so calm and so nice. And you couldn't tell whether, when you looked through the window in the operating room outside, whether he was up to his neck with alligators or it was just a regular case. I can remember him. We were supposed to go to a Montreal meeting, and we were going to drive together, and we were doing a third time redo, aortic bentol, whatever. It was just ridiculous. And he just put his fingers around, and the whole aorta fell to bits. And he just said, well, I guess we're going early to Montreal. We're done. And it was just like that. He didn't scream, he didn't yell, he just said, we're done. There was no way for it. And this, when you train with somebody like this, who is calm, who is kind, who is a little bit witty, and you just, you imprint on that like a duck imprints onto its mother. So I think these are really things that really helped me. Fitz and Keon were my mentors. And they made me who I am.
I share your opinion about nurses. I believe that there is no good surgeon without good team, not only nurses, perfusionists, and everybody. We highly appreciate everybody's work and input in our everyday's work. As someone who is starting with mammary arteries like myself, I already have maybe around 20 mammaries. We don't use harmonic scalpel here. I was planning, by the way, to play you a video of mine while harvesting mammary artery, but
I'd love to see it sometime. Okay.
but in the last moment, I saw that I don't have an agreement from the patient, so I can't share that,
Just
unfortunately.
get it and we can do it another time. It's okay. I'm
Yes.
here for you. Okay. I'm not going to be just as the one-off time. If you need any help, any of you, please just email me. Might take me a while, but I'll get back to you. I've got lots of things happening in my life, but it's okay. I would
We
love to
highly
help.
appreciate that.
Yeah,
we highly appreciate that. So, what are your tips for mammary artery harvesting? Do you open the pleura? Because there are a lot of discussions about it.
I don't. I don't open the pleura because if you don't transgress the pleural cavity, you are going to less likely have pleural effusions. Okay. Now there's caveats. There's pros and cons for both, because if you don't open either pleura, then you are more likely to have a nasty, if you're bleeding, it's likely to end in tamponade, and you got to get there fast because you've got nowhere for the blood to go. But on the other hand, if the blood's got somewhere to go, I had one case, they didn't do an x-ray. We went through a phase, God knows why, of not doing x-rays after surgery to save money. This is, every center goes through silly things like this. And they didn't know until the next day when her blood pressure dropped and her hemoglobin was tanking and the chest was full of blood. So, the thing is, I like to keep it to the mediastinum for infection, for, and for just sake of less pleural effusions. Now, having said that, I can probably take the left mammary down without getting into the left pleura about 95% of the time. The right pleura, no. It's usually 50, 60% of the time I can maybe preserve it, or even less than that, because I find that maybe it's because there's 3 lobes in the right line, I don't know, but it's the pleura is thinner. It's thinner and it seems to break a lot easier. So I try, but I can't do it all the time. But it just helps with later on down the road. Pleural effusions are annoying, aren't they? I mean, sometimes they can be very dangerous. The patient can go home and don't realize that this shortness of breath is not normal, and they come in extremis because they can't breathe. So anything you can do to minimize a complication for a patient is perfect. Is the way to go.
And another technical question about radial artery harvesting. I use vessel loop for harvest. Yes, I love them.
Yes.
I just catch the artery and I go with the cautery left to right, and it's done. But there are always comments about that it can somehow, but there are no literature, there are no scientific proofs that vessel loops somehow can damage the intima, for example. What's your opinion about it?
I wouldn't think that would. You're pedicling the radial, right? You're not taking it skeletonized, first of all.
It's pedicle.
And if you're pedicling it, I can't see it. The only thing I can, if you want to use, sometimes they have those Penrose drains, the thin Penrose drains. They're about this wide. That might be a little less, but I can't. But if you've got a pedicle, I can't see that damaging, because we do that with off pump surgery. When you're doing a Lima LAD, you've got a silastic loop on the proximal and the distal artery. So if you can use it there, I think I can't see that. And you're not pulling it up like this, are you? You're just pulling it up just enough to see.
Yes.
I'm sure you're very gentle, teamwork. That's perfect. I think that's a good idea, actually.
I will send you some videos and you can comment them.
I would love to. Now, listen, do you use the focus harmonic scalpel for that?
Unfortunately not. We used harmonic scalpel in my homeland. I'm coming from Bulgaria, and I know that you visited us in Varna. That was
Oh, yes, and Sophia as well.
right.
Yeah,
But
no,
at that time, I was, I believe, first or second year student. But it was my first interaction with you. But
Wow. Oh, were you there then?
yes, but
When I was in
as,
Varna? Oh my God.
but
So
as
we
I
found each
say,
other again.
I
yeah.
don't, I remember the fellow. I can't remember his name, but you were one of the ones that were watching, right? Or
No.
were you doing?
Yes, I was there, but as I said, I was student back in the time, and I
Yeah,
was so
yes,
shy,
right.
so I
Your-
I was in the corner.
Well, your fellow or resident, wherever it was, I remember teaching him, and I quote him all the time because after about 5 minutes, he suddenly turned to me and said, "This is easy." And I said, "I know. Good for you." Because it is. It's much easier to do it. But it is coming back, the harmonic. I think the Japanese have it now. And we kind of went to bat, many of us all over the world, but I don't know what stage it's at yet for the general public, but or the general surgeons. But I've told everybody who uses it, and I have emails with people all over the world, for God's sakes, talk to your Ethicon rep and just say, I needed it, and keep bugging them. It's the squeaky wheel that gets the grease, okay? But it is really good. Did I answer your question? What was it?
The
Oh, yes,
question,
it's elastic. Yeah. No, that's safe. I think that's fine. That's perfectly
But
fine.
since we're already talking about the harmonic technique and harmonic hook plate, I'm sure that some, especially our younger listeners, do only know skeletonization using cautery tip. So if we're already talking about that, could you please maybe summarize or explain why is it that easy? What is special about this technique?
Okay. Well, I've got videos I could show you, but you can see the videos on your own. First of all, I started skeletonizing in 2000, okay, and skeletonized, I think the harmonic scalpel I started in 2003, I think it was. Yeah, November 2003. And before that, I was using the cautery tip as a dissector with no power. I worry about power even a little bit. They say, oh, it's just a little brief. But the lateral thermal spread of the harmonic scalpel is 0.1 millimeter. In other words, when I touch the mammary artery for a second, I'm frying 0.1 millimeter. When you touch the mammary artery or get close to it, your lateral thermal spread is 1 whole millimeter. And how big are our mammary arteries? They're 1 to 2 millimeters. So you're frying the little suckers. And you remember when that Compass trial came out and they said, well, the skeletonized patients didn't have as good a result as the pedicled patients, mammary arteries? I think it's because when you have, and I can't prove this, it needs to be a study or somehow with experimentally, because you wouldn't do it on patients. If you touch a branch and it extends 1 millimeter, you are creating thermal damage. And thermal damage doesn't happen right away. Like we know with a burn, it takes days for it to be scarred. So you may see sort of problems with the mammary artery 3, 4, 6 months a year. I may be talking out of my hat, but it doesn't seem the right thing to me to go anywhere near a mammary artery with any cautery at all, unless the branch is about a centimeter long, okay, like well away. But how long are the branches? They're 1 to 2 millimeters, aren't they?
yes,
So I think
right.
it's faster because what you're doing is one lovely student from the EX Academy, when he was practicing, because we do this at the EX Academy, we have harmonic scalpels, and we have 4 stations with pigs' torsos, and the 2 wet lab guys there, Chris and Kevin, they take out the breastbone. No, they take out, what do? They put it prone. They take out the backbone of the pig, put the pig prone, and the mammary arteries are sort of on here, like on here. And they've got 1 mammary artery, 2 mammary veins. So the students have 4 mammary things to harvest. So when he was doing this, he looked at me and he said, it's like painting the mammary. It's like airbrushing. And And it is. You just go, it's so fast. You don't have to, when you do a technique with the cautery tip as a dissector, you usually you pat it, you drag the tissues along, and it causes bruising, it causes hematomas. You don't get that with harmonic scalpel, much less damage. And you do clip, clip, cut. And now if you think that when you're sitting on a branch of the harmonic scalpel, you're sitting on it for maybe 1,000, 2,000, 3,000, that is still less time than clip, clip, cut. It's because you're doing something, you think you're being fast. Whereas if you're sitting waiting for a branch to go black and then white, you think it's slower. But I timed it. And I think my paper showed that, and pedicled was 19 minutes average. The nurses used to in our hospital, I don't know why, they treated mammary harvest like an operation. So they were timing that operation. When you started the mammary artery, they started clocking your time. And when they finished the mammary artery, or the second mammary, they clocked the end of the clock. So for the first, 15 years of my career, 20 years of my career, I had times. And I thought, this is kind of good. So I got all the times, and I started timing myself because they stopped doing that for a while. I started, for the last 100 cases before I wrote the paper, I timed the mammary with the harmonic scalpel. And pedicle was 19 minutes average. Harmonic scalpel to start was like 35 for the first 20, then 30, and then it went down. And then the last 100 that I did before I wrote the paper, it was 15 minutes. And then there's some, that means the average is less than that. Like some patients who are not too thin, not too fat, you can do a mammary in 10 minutes. That doesn't happen with other mammaries. So can you imagine your day in the OR, okay? Your day in the OR is governed by time. You can't do the second case if it's too late, So if you do 2 mammaries, either pellicled or skeletonized with not the harmonic scalpel, it may take you half an hour, to do 1 mammary one side, and that's the usual, 25, 30 minutes. And if you can do it in 10 minutes, okay, if you do it without the harmonic scalpel, you've got 2 hours a day. If you're doing 4 mammaries in a day, 2 cases, you've got 2 hours, right, of work. Whereas if you do it with the harmonic scalpel, if you've got good patients, you can do it in 15. That's an hour. You're cutting an hour of OR time. You're getting out at 6 o'clock instead of 7 o'clock. The team will love you. I mean, I remember, I'm sort of digressing so much for you guys, but stories are so funny.
No.
I met and knew Ottavio Alfieri, okay, and at A Coruña in a conference there, and we just hit it off. We started talking, and he's a valve guy. Obviously, he doesn't do that many bypasses. And he said at one point, he said, "Teresa, you are very interesting to talk to, but tell me, what is it like to do so many arteries?" And I said, "Well, Ottavio, and pardon my vernacular, you please the people you work for, and you piss off the people you work with. Your patients love it because you're not cutting their legs. They don't realize that in 20 years, they're probably going to be still fine. And the cardiologists love you because they know what arterial grafting does. And your team is annoyed with you because you're taking longer. And your colleagues think you're grandstanding." So, and he just said, But you still, if you believe in something, you must do what you think is right for the patient. And I just want to digress a little bit. And very importantly, tell you, never listen to naysayers. There are many people in the world that have trouble fulfilling their true talents, and it makes them feel uncomfortable when somebody else beside them is just going, me. But they will try and take you down. They will try and bring you mediocrity. Don't follow the crowd. Don't follow the crowd. Keep on doing what your heart tells you, not your head, what your heart tells you. Donna Strickland was a physicist in Guelph, Ontario, Canada, who was a winner of a Nobel Peace Prize in physics, okay? And she was the 3rd woman ever to win this and the 1st Canadian. And she was asked, and I remember this, it was back in 2020, And I hit the news, and she was asked, what would you tell young people who are interested in a career in physics? And she said, well, she said, if somebody says something and you don't agree with it, you just say to yourself, they're wrong, I'm right, and you keep on going.
Yeah.
I was told in fourth year medicine, when I said to the general surgeon I was working with, I want to be a general surgeon. I want to be a general surgeon. And he said, why? Who's going to send you business? You're a woman. And I thought, oh, I didn't get upset. I didn't get angry. I thought, oh, maybe he's right. There's a point to this. And so in my internship, I did a rotation in general surgery first with a wonderful surgeon by Ray Matthews. We hit it off. I had a wonderful time. And then I went to my rotation in plastic surgery. I walked out of the only operation I have ever walked out of. I walked in my first day, and there was a patient awake, sitting in one of those kind of reclining chairs with a white cloth over his forehead. And the surgeon, it was a rhinoplasty, excuse me. And the surgeon had a little mini anvil or hammer and a thing, and he was chipping off bits of the bone, and blood was streaming down. And I just thought, my God, I can't even watch this. Never mind do it. This is probably my bread and butter. So I left the OR right away. I went right back to Ray Matthews. I said, Dr. Matthews, what am I going to do? I was told I'd never get any business. I'm a woman, but I don't want to do plastic surgery. I just really don't. And he just exploded. He said, for sake, he said, you should do what you want to do because you will be best at that. They told me I'd never be a teacher. Here I am, a professor at the University of Toronto. So this is a very important message for all of you. Don't let anybody ever dissuade you from what you feel in your heart you must do.
Yeah, that's such an inspiring statement. Actually, thank you for that. And I want to dive into this topic a little bit more because you've worked at Full Health Medical Center for many decades, like more than 35 years. And during the most of the time, you have been the only female cardiac surgeon actually in the area. And unfortunately, you face gender-based discrimination. And you took a courageous step by filing a complaint against your employer, Better Health Services. And I would really like to know what advice would you give to female surgeons who find themselves in similar situations? And how would you say, how should we identify gender-based discrimination, even though it's most of the time quite implicit? It's hard to get.
It's hard. It isn't obvious anymore. It's very subtle. And I'm doing this not for I'm in the last stage of my career, which is, I love it because I'm teaching most of the time and internationally, but it is, I think as I was going through, I didn't really, it's like when the surgeon said to me, well, who's going to send you business? You're a woman. I never took offense at any of these things. I just thought, okay. But then when things started happening to me I used to dread coming back from my trips abroad because I was wondering what they were going to have in the wait for me. And I thought, I thought the best way to do this is do what Jesus did. Just take the higher ground and just ignore them. Fight every fight that they had. And I had a CMPA lawyer for the last 20 years of my career, protecting me. And every 6 months to a year, there'd be something else that would just come up. And it was hard to work under because it was hard to watch your back all the time. But I felt that if I took the higher ground, if I just kept my nose to the grindstone, trying to help patients, make patients complication rate less, that I would ultimately triumph. And I think nowadays, you almost have to be, it's such a fine line because, Ruth Bader Ginsburg, who is one of my absolute all-time heroes, I wanted to meet her before she died, but she bloody well died. Anyway, and she said, you can disagree, but you must disagree agreeably. So, it's one thing, I remember one of my cardiology good friends said, you can't bark at them because you'll be labeled a bitch. you know? There is a double standard, but you can be, let's see, I'll give you one little example. I was, I guess, very naive. My mother wanted me to go into a convent because she figured I'd be safe there. She was worried about me being run over by people. But I was doing my Royal College exams in general surgery in Montreal General Hospital. And my last question, and then we had this big screen that was the whole room size, okay? And they put up this picture of this little aperture of the human body somewhere with a few hairs, black hairs sticking out of it, with a little red ball on the outside of it. And they said, there were two male examiners, and they said, "What is this?" And I said, "It's an asshole," because that's what it was. It's a thrombosed hemorrhoid. And I was only thinking the other day as I was giving this talk, I was preparing to give this talk to you guys, and I thought, you know what? This, in a way, was gender discrimination, because they wanted to make me embarrassed. They wanted to make me get all nervous and then not say what I said. But I hit them between both eyes with a 1-2 punch. And so if you can do this calmly and efficiently, you have triumphed. You can never let them get to you. Never let them see that you're bothered. Never. You just glide on by. But you have to some way tell them that you don't like this treatment. And that's where the difficulty comes in. You know, maybe one-on-one. But in the Bible, it says you go, first of all, if you have a disagreement, you go talk to the person. If they don't, then you take somebody with you, and then you take all people with you. But again, you've got to be non-judgmental, because I honestly believe when I'm doing all this human rights thing, there are three reasons why this happens. One is human nature, which we all have. Two is professional jealousy, and in my case, a woman. And three, unconscious bias, which has been with us for millennia. It was back in the 2000 BC where women were nurturers, and men were this happened. This is what we've all grown up with. And Robin Sharma, I just read the other day, I do a little daily meditations, and my daughter gave this book, and it's like, everybody has flaws to mend and wounds to heal. And I think a lot of the times people don't realize they make a snark comment about, oh, it's a woman, They don't realize what they're doing. So my main purpose is for education and for the women who follow me, is to let your hearts become unhardened, not hardened. So that's why I'm doing this. And I'll tell you one little story. It was lovely. This happened in 2020, I think, when it started coming out. And every day and every week in the hospital, there was one time, I'd be walking alone in the heart, and there wasn't a day or a week that didn't go by since then, even just recently, in the last year or so, where somebody would stop me and say, this happened to me just like what happened to you. And it was not just women, it was men. You have bullying in every walk of life, in every gender and expressed gender, okay? It's just the way it is. And one little nurse one day, she said, "Oh, Dr. Kieser," she stopped me always when I was alone, walking the hallway. She said, "Oh, Dr. Kieser, because of your bravery to do this, I am standing up to one of my managers that has been bullying me for years." And she said, "I think this is probably the most important thing you are doing in your career." And I thought to myself, I've only operated or talked about 6,000 patients. Isn't that worth anything? But she's right, because, okay, I've operated on 6,000, maybe seen 2,000 more patients, but I hope I will affect all women, which is half the population of the world. So that is what I'm about now, as well as teaching you guys.
Well, maybe that's the moment just to comment how we appreciate the philosophy of our department here in Jena, Germany. Our mentor and the chairman of our department, Professor Dunst. We have examples. The first chairwoman in Germany, Professor Gloria Ferber. She's
Farber, yes, I know her very well. We're good
yes.
friends. She's lovely.
She worked
You're right.
in Jena, and now we have more than 4 or 5 ladies. So we are really, and we prove that we can work excellent together, no matter the gender or the nationality.
We need each other. We have different gifts. You need women. Women need men. We have different gifts. God put us together for a reason.
Yes.
It's so wonderful. Gloria is wonderful. Please say hello to her for me. She's a very special lady.
Another technical question from my side. What is your opinion about that way of learning operating bypass in few institutions? In our institution is so as well. They start first on pump bypass grafting and then off pump. I already spoke with few colleagues that they started directly with off pump. What is your opinion about it?
It's hard to say. I think, as long as you have had some experience in practicing anastomoses, like, Paul Sargent with his, and I remember he telling me once, he says, I don't let anybody touch a human until they've done 1,000 anastomoses in a lab. If you've done that, and I think that's actually, 1,000's a bit much, but but if you did some practicing, like I had a little kit in my office that I would have the residents come in, and actually got it all from Amazon.com. Can you believe this? I got ringed forceps. I got, needle drivers and Castro Viejo needle drivers there were short ones, and I would just have a little kit. And we had one of our residents who was very inventive and made a kit, a ball that you could operate on like off pump. And I have them in my office, and I teach them. I say, no, I like this. That's good, but I teach them like 1 millimeter bites, square bites, 1 millimeter long, 1 millimeter deep, and I just teach them in my office, and they get visibly better the next time they try to do it. So I don't think it much matters. If you're on pump is good, but it gives you security of having a very still field and everything. But again, it's different. As my mother said, you start the way you mean to continue. If you think you really want to do off pump, and now with minimally invasive and everything, it's all off pump, right? So I think you really get, when I did I did 80% off pump for about 3 years because I was involved in putting patients in the coronary trial, and I wanted to make sure I was okay. I didn't enroll patients till I'd done at least a couple of years, and I found that I was so much better at off pump or on pump, so much better on pump. So I think it makes you a better surgeon. I remember, I don't know if you know of Ralph Demiano, who was the Cox Maze guy. Well, he said to me once, he said, Teresa, the hardest operation in all of cardiac surgery is a total arterial bypass off pump. So if you could start with that, you're going to be right away to the races. So whatever way you learn, just practice beforehand before you get on a human.
Yeah. You've been talking about teaching and education in surgery, and I think that's another major topic we should talk about, because you've been educating and teaching surgeons all over the world. You've been teaching for the European Association of Cardiothoracic Surgery, for example, and you've been traveling a lot of countries, including Bulgaria and other European countries. I would really like to know, why do you think it is so important to travel and to connect through surgical techniques and to build international relationships in our field? And what could we learn from each other across borders, like professionally, but also on a human level?
You've just answered it all yourself with what you've just said, Angelique. It is, I have never been in an operating room, and I've been in many, that I have not learned something. I have not learned something, and it may be human nature. It may be but techniques for sure. I go, wow, that's a cool thing to do. I'm going to do that. So my techniques are a combination of everybody's, and I think you just remember I was in. I think it was in Munich. I was in an airport, and there was those Teletron things they have, and there was a saying, because they intersperse news with sort of sayings from people, and the saying was, "Those who never travel is like reading only the first page of a book." And do you know who said that? Saint Augustine. So you learn so much. You won't hate anybody if you know them. It's not the people that are the problem, it's the leaders sometimes, but I've never come across any team or any people in the world that I haven't instantly loved, because they respond to the way you respond to them. Your positive attitude, and you've got to be tactful. You've got to be, quiet in the operating room. I go very carefully I do a lot of proctoring now in the ORs, which I find is really huge. I've been doing this since about 2022. And I can remember being in Israel, and it was just, it was amazing. And it was anywhere, because when you're teaching, I teach a lot of arterial grafting and intraoperative graft assessment. And it's one thing to give a lecture to 20 people. Maybe one will pick up what you say and go and try it. Whereas if you're in the OR, oh my God, I was in one OR in Montreal, and the surgeon was very tense, very tense. So I was very quiet. Didn't say anything, just quiet. And I would come in, or just, if I was scrubbed or not, I would just sort of make a comment if he'd ask me. That was it. And at the end of the case, his bypasses were beautiful. Well, at the end of the day, and I've been warned by the rep, the Medistim rep, that this guy is not too keen on doing this, okay? At the end of the day, when the second surgeon is going through, and he's just finishing up, this morning surgeon bursts into the OR and says, "What were your graft flows?" I thought, got one. So you just being there and troubleshooting with, and I say, well, that's funny, you don't want to revise a graft if you don't have to, and most of the time you don't have to. So I just said, what was the stenosis level on that thing? And the anesthetist said, "I can pull up the angiogram. Here you go." I said, look, it's only 60%, and in a couple of views. So maybe you're getting some competitive flow here. And they go, okay. I said, "I'd leave it. Don't touch it." This is 10 times the value of being in the OR troubleshooting with somebody. So yes, traveling is huge, according to St. Augustine. Good, very good question.
How do you manage difficult targets, small vessels? How do you have some tips and tricks to deal with that?
Oh yes, yeah. Well, I think first of all, if it's bad enough, I do it on pump. Okay, I can remember doing one in my off pump phase, taking me hours and hours to do, and I think I redid 3 distals and 1 proximal, because I was bound. I was doing off pump. I had to do off pump, and when I finished and the patient did fine, my scrub nurse, who was a little bit bold, said to me, "Dr. Kieser, if you were going to revise one more graft, I was going to shoot you." So I said, "Okay, Tara, I rest with that, because I think you're right." And so if it's difficult, I do it on pump. And I'm not shy about doing endarterectomies at the end of the LAD. I've got multiple techniques that I've devised over the years for complex targets. I mean, I can describe them to you. I've got pictures and videos and stuff, but I got pictures, diagrams and things. But one is, when you have a very calcified artery, the lumen is good. Okay, you've seen the angiogram, but it's like calcified right to the apex, and you're going, and it's got ischemia in the LAD territory. I will carve an ellipse with the beaver blade, which is a very sharp little beaver blade. If you do have those, I don't know. I carve an ellipse, a tiny ellipse in the front wall of the artery. And and anastomose to that. Because if you go distally and it's less than 1 millimeter, it's not going to cut it. And this one technique came from it's on CTS Net, I think, a lady who lived, I think, 20 plus years after this happened. She had such diffuse disease that the cardioplegia in the vein graft, it was using vein, it was like 19, I forget anyway, the vein went back and the vein graft was attached to a marginal. And when it did this, it lifted a plaque, it lifted a flap of atheroma, went up to the left main and down the LAD and dissected the whole, pretty much left heart system. And I didn't know this, except when I was doing the proximal, I looked to the aorta and I did the punch and I went, oh, I saw blood coming out of 2 lumen, the middle one and the side one. And I thought, I still did it. We came up pump and my anesthetist, who was a really wonderful man, never got upset with anything, but always he says, Teresa, we have a problem. So what is it, Richard? He says, the whole left heart is dead. I went, okay, let's go back on pump. Because I knew in a flash what had happened. The cardioplegia, and at that point, our cardioplegia had a flow pressure of about 200. Ask your cardioplegia, what is the flow from the pump coming? What is it? Because from that day forward, I kept it down to 80 when I would put my cardioplegia down vein grafts. And I did a second bypass. I think I'd done a second bypass before and did an endarterectomy, the marginal. And so when I went back on pump, I thought, okay, I know what's happened. I know that the dissection has gone up, and he could see, the videos are great. You can see it, the flap of closing over the orifice of the left main. Okay. And I said, okay, I know what I'm going to do. Give me a piece of vein. And I carved, and I left the mammary I'd put right at the end of the heart, like with the 1 millimeter artery, which was still looking like it was working. And I carved a little ellipse in the middle of it and just put the vein graft there. We bounced off pump because we'd only been off pump for like 10 minutes. And ever since then, I thought, okay, this is a technique. I can do this. So if they've still got it on CTSS, I recommend you looking at that case, because it's really, and I ran into another surgeon. I presented that talk at some meeting in Miami, and it won like a prize for the best case kind of thing, because nobody believed that this would ever work. Nobody believed it. And I remember telling one of my colleagues, my surgical colleagues, I said, look, John, look what this happened. He looked at me, Irish. She goes, Teresa, you had a guardian angel sitting on your shoulder for that one. So anyway, it's what are we doing for time? You're getting up. You guys have got to go soon. But there's many things you can do. I'll do one last little one. Purse stringing, when you do an endarterectomy, it gets a lot bigger. Okay. And I had a side to side, it was 6 bypasses on a young man. And I was doing a side to side anastomosis, and the hole in the artery was this big. Well, not this big, but very, very much bigger than what I would, the cruciate, because you have to do a little one, right? So I just did like sewing. I went 2 stitches in the native coronary artery, 1 in the conduit, 2, 1. And I purse stringed evenly all the way around. And I got a CT angio 6 weeks later or whatever, because I wanted to make sure this worked. Anything I do crazy like this, remember when I talked about using the Foley catheter for retrograde? I still do crazy things. And at least I call them crazy because it's not tried and true. It's something you have to fix right now. You've got a problem, and it was perfect. Flow was great. So that's another adage. You can connect anything to anything, as long as it's technically perfect.
And what is your opinion about any aortic approach in bypass surgery? Do you connect the radio with memory?
Yeah. Oh, yeah. No, I usually try to do in situ, but if you can't, yes, I do WISE for sure. WISE, Y from the Lima, the Rima, the radial, and even saphenous vein. I remember Keep On Kim has a paper out like 2020 saying that if you attach a piece of saphenous vein, mind you, he does an incredible job of no touch technique and getting rid of the valves and everything. and I think it's true, the patency of the saphenous vein attached to a mammary artery is better because you don't have the pressure of the aorta on the vein, and you've got the nitric oxide and everything of all the good things, prostaglandins from the mammary protecting it. So, yeah, no, aortic it's definitely, you can't get a stroke. But, you know, again, it's like 1%, 2% have strokes, but that's terrible. So, you know, if you don't touch the aorta,
Yeah.
it's very good.
You've already talked about like getting stroke and other complications, and you've also talked about revision of grafts, and that there's another thing you're made significant scientific contributions in. It's transit time flow measurement in the OR, and of course, in general, intraoperative graft assessment. And I think TTFM is something that is more and more commonly used in the OR, but you are a great expert in this field. So I would love you to summarize what, how, when, and how to interpret TDFM in the OR, because there are different numbers like positivity index, mean graft flow. So what do we have to keep in mind on that?
Okay. So there are two modalities for full assessment of intraoperative graft assessment. One is transit time flow, TTFM, and epicardial ultrasound. Now, TTFM is very, very good. I think if I had an elective case and I didn't have either TTFM or ultrasound, I would cancel the case. I believe in that strongly. Okay, elective. So, TTFM is very good. It gives you function.
Yeah.
And the PI I go by is 5, but I like it when it's less than 3. And the PI is the most important. Flows depend on so many things. You can't really say a good flow means anything. I mean, for example, if you have a lima to the LAD, say it's like this, okay? Here's the lima, here's the LAD. And if you have a stenosis at the toe and it's only going retrograde, you've got all the septal perforators, which is huge. I mean, the LAD supplies 2/3 of the left heart, right? So you can be full. I remember I had one of my colleagues said, I've been full 3 times now. I thought the flow was great, but the toe was blocked 3 times in a row. I say, well, you get bigger loops or something. Anyway, so you can be full with transit time flow. And about 5 to 10, not even, well, maybe 15%, you're going to be scratching your head going, is this a case? Is this not? Is this, so I have to revise this graft? And nobody likes to do graft revisions if you don't have to.
Of course not.
Make it worse, Yeah. So, you can do several maneuvers to rule out competitive flow and that sort of rule in competitive flow. The maneuvers are bringing up the blood pressure, giving a little bit of dopamine, ask your anesthetist to bring the pressure from mean of 60 or 70, which is usually what they're running at, to 80, 85. And what's supposed to happen? If you bring up the pressure, what should happen? The PI should go which way? What do you think?
Down, I think.
Yes. And what would the flow do? Goes up.
Up.
Okay, up. So because it's going down. The other thing you can do is, and so then you know that it's fine and it's competitive flow. The other thing you can do is a proximal snare, especially if you're doing on pump already. And I used to do every off pump I measure the flow through the graft with the proximal snare on, because then you're getting rid of all the native flow, which is, if it's only a 60%, you're going to have a lot of native flow, or 70%. It's still a lot of flow. So you can measure, then you can rule out that way. The third way is with the ultrasound. The ultrasound is extremely important. It's probably, it's just as important. Well, it's probably a little more important because it corrects the deficiencies of transit time flow, and those 10 to 15% of grafts that are equivocal numbers. The PI is maybe borderline 5 to 5.5. The flow is borderline less than 30 for a mammary, less than 20 for a mammary. The diastolic filling and the waveform looks really funny, like bizarre. Whereas if you have the ultrasound gives you anatomy. And we're used to looking at anatomy. We look at angiograms all the time before we do our cases. So same when you have many views of an angiogram, you do a longitudinal and you do a transverse. And you can even do longitudinal like this and give like the angiogram. So you can tell, because sometimes you have to bypass really diseased vessels, right? So you can also find where to put the best place to put the bypass on. So Gabriele Gimarco did a wonderful paper, I think it's back in 2020. He compared the use of TTFM and ultrasound, and I think he had 0.7% revision of grafts, which is crazy. It was really, but about 39 grafts had equivocal transit time flow, like looked like there was troublesome. And he ended up with only 2 or 3 grafts, I can't remember the numbers exactly, where there was a problem that was corroborated. TTFM said it was bad, and the epicardial ultrasound collaborated, yes, that said correlated, said yes it is, or vice versa, the TTFM was good and the epicardial channel was not good. And so of 30, it was 2 grafts of 39. I remember that because I thought to myself, this paper, they didn't even say it in the paper, this paper proves that they prevented 37 of 39 graft revisions. So that says it all to me. Ultrasound is the bottom line. So I cannot emphasize more that you should be using it. It's so good for your training. My God, you leave the room and you're happy. You're a staff. You're at night in your bed and you're happy. Because they're not going to call you. I've even come in some days and they said, "Oh, Dr. Kieser, we did angiograms on your patient because we were worried about graft." And there was some ST elevation. It was probably pericarditis. And I said, "Oh, really? I had to show." "Oh, yeah, they're fine." I said, "I know." Well, I didn't say that, but I thought to myself inside, I know, that's why I use this. And I stopped. And when I started using it, up until that point, I think it was 2003, April 24th, I started using it. And before that, I had anywhere from 1, maybe 2 patients a year that would suddenly crash, as Dr. Taggart is fond of saying, at 11 o'clock at night. They're calling you not to tell you your grafts are good, but your patient's crashing. And I had 1 or 2, and a lot of them died. And that's the paper that came out that changed the whole ball game. I mean, even at that point, I had been using it for about 3 years, the device. And if a graft was obviously bad, I mean, the blood pressure was dropping, echo showed a regional wall immersion abnormality, and the transit time flow was really bad, I'd revise it. But if just the transit time flow was a problem, because I wasn't using ultrasound then, I thought, oh, it'll be fine. And it was those patients that many more, significantly more died, significantly more had major. So I was believing a machine. I was believing myself over a machine. So it's not really arrogant. It was not knowledgeable at the time, but now it would be arrogant because I know the machine is better than what I can do. I can't see inside there, once I've done the anastomosis. So it's very, very important to use, and it's great for trainees. Great.
And why it is important for a trainee to be involved in science since his or her early days? Because in order to know what is right and what is wrong, we have to somehow scientifically prove it. So what is your opinion about science in early education?
Oh, well, that's a very, very good question. It's one of my real heart center problems that I think what it does, we are in a specialty that is fast moving, and you can't just like a plumber learn to use in your craft and then go out and do it for 20, 30 years. Even plumbing, and probably it changes, but we have to keep up with the times. You have to develop an inquiring mind. You have to constantly be asking questions. I mean, I'll give you an example. If you constantly, and science does this, if you're involved in scientific endeavors, you have this, what is science? It's just asking questions and getting answers, right? That's all it is. I remember about year 2000, I had not had a deep sternal wound infection for 2 years. And I'm going, holy free holies. And so I had a wonderful, good statistician. We're good friends. And I said, "Sarah, do you think I should write a paper on this?" She goes, "Well, let me do the stats." So how many patients I'd done, and she said, "You need to do another 269 patients or something like that to see if this is statistically significant." I went, okay. So I waited. It took me 2 years, 169, whatever it was, 2 years. And so we wrote the paper. And what I had done, all I had done was take, like, if there was a resident who came from BC and he said, "One of our surgeons is using vancomycin bone paste." on the sternum, to prevent infection. I said, that sounds like a bloody good idea. I'll use that. Again, the early adopter thing. I don't need to, if something sounds sensible, do it. And I'd never used bone wax because I worked with Jim Cox for 5 months, and he never used bone wax. He says, no, it's a foreign body. It's not good. And so I thought, well, this makes fine, good to me. I'd start my practice, but I started without bone wax. And then I started skeletonizing. That's something that prevents infection. And then we, as a group, our whole group had too many infections in Calgary. This is back in 1999 or something, and so we switched from betadine, skin prep, to chlorhexidine alcohol. And that made everybody's infection got better. It was down like 50% or something. It was really good. And there was many things that I just did over the years like that. And I kept a chronological list. I had a little piece of papers, and I had wrote down every operation I ever did, the time I finished, because I'm trying to keep the time down for staff, and the actual operation I did. And then I had a separate page when I started. That's how I know when I started using the harmonic scalpel, how I started when using the transit time flow. Because then if you start and use it with some and not with others, you can't compare. You can't. It was this point it started. So from then on, you used it on everybody. And if you're going to learn a technique, you should do that, because then you're going to get good at it. If you only do it on the really best patients, you're not going to learn how to do the technique. So if you change something, write it down. And then you can go back and go, hey, at that point in time, this happened. And then after that, for 400 cases, this happened. Paper. Simple. Just keep your mind open to answering. If you notice something, if you find an unusual anecdote, okay, one patient, okay, that's an anecdote. That's a case report. But if you wait and find several, that's a series. And if I have several more, that's a retrospective review. And what does that lead to? Randomized trials. So you are constantly learning. If you constantly learn, you will never get bored. You will never burn out.
Yeah, that's so true. Yeah, our head of department always used to say something really special. I think that comes along right away. He always says, if we do not step up academically, we will step out of the operating room. I think that's a nice sentence. Works well with everything you already said. And
well, he's right. He's absolutely right, because
I think so
it's
too,
easy
right?
to do, really. It's fun to do it. It's fun to find something that's, transit time flow for me was like, holy free holies. This makes a big difference. I haven't killed a patient in 5 years, like suddenly, kind of thing, from a graft going down. And if the graft does go down, it's usually not so bad. It's maybe a 60% narrow or something that progressed. It didn't kill them. But I didn't have anybody who just dropped dead after surgery, which does happen.
Yeah, of course.
I'd love to be perfect, but I'm not.
Let's talk about training a bit more, because I'm really curious. What are the green flags, so to say, in a resident that you see, and did you see his potential?
In a resident. Okay. Oh, I just think the biggest one is listening to instruction.
Okay.
Biggest one. And getting better from that. And work ethic, obviously, but and asking questions and having an inquiring mind. Why does that happen? Why does that happen, Dr. Kieser? Well, what if we did this? And then you can and then that's where the two-way street begins. You've got to have an inquiring mind. I don't know how people manage to live without it, because it keeps you going. It keeps you interested. It keeps you interested.
And
without it. Go ahead.
Since we are heading to the end, unfortunately, of our conversation, but we will leave the door open for a second, third, fourth one. It will be a great pleasure for us to keep in touch with you. One last question.
Yes.
What is your message to all resident students all over the world who are interested in cardiac surgery and somehow are struggling maybe somebody is struggling with memory artery, the other one is struggling with understanding what is randomization, the third one the third one can perform sternotomy. What is your message to all of us?
You know, I think something my father said, all beginnings are tough. And you just have to be patient. Patient is the biggest name of the game. We aren't meant to learn everything all at once. We cannot. Our brains can't handle it. So one step at a time, get rest, get sleep. Okay? This is extreme. I think doctors, in one way, COVID did us a favor almost because, well, they did us a favor because when COVID came out, I could be at the 7 o'clock rounds and still be in my bathroom getting ready for work. Listening to the rounds from my cell phone. I didn't have to be there at 6:30 in the morning, and our lifestyles are not conducive to rest. So you do need to get sleep. And just if you've got a Fitbit, I've just started doing this lately. Look at if my Lux gives me this, the amount of deep sleep you get. Because the deep sleep is when your autoimmune system regenerates. And this is very important to get sleep. You'll be much better off if you have sleep. You can help people more. Staying up late studying and stuff and then trying to operate all day the next day. We all did it. I've done it for 36 years. And it'll catch up with you. So don't be thinking that and don't pay attention to naysayers. Just follow your heart and just keep working at it. It will happen. And it's tough at the beginning. It's tough. Oh, I could tell you stories. That'll be another day.
Dr. Kieser, thank you so much for that conversation.
You're very, very welcome. You're delightful too. If you've got interaction with anybody who wants to email me, I'll try and answer. I'm in the middle of moving maybe to Vancouver Island, but I'll get back to you eventually. Okay.
Well, thank you so much.
Thank you so much. It was such an inspiring talk, and there were so many statements that will keep in my mind. I thank you very much.
You're very welcome, and thank you for being such a lovely audience, and I hope all you out there are enjoying it too. God bless you all.